Hello, everybody. Very warm good afternoon to everybody. All those who have come here all the way, and most importantly, you have employed your such a precious Sunday onto this biomechanics class. So thank you so much, everybody, for coming here and for waiting here. We'll be taking say a few seconds more, such that everybody could join in again, and we can start. Hi, hello, good afternoon, everybody. Good afternoon, all those who are here already here. Very good afternoon. Welcome. I really appreciate. Hi, good afternoon. So, I hope you've had a wonderful Saturday yesterday. So today we'll be starting with the biomechanics of the posture, the second part 2. कौन बनेगा करोड़पति II. Okay, now the second part will be starting today. Chali. Without any more delay, let me start sharing with my screen. Okay, let me start sharing with my screen. All right, if anybody has any problems with the yesterday's class, you can share to me anytime. I hope you people are able to see what am I showing. All right, so today we'll be talking about the most important and the most interesting part of the biomechanics of the posture, that is the kinematics of the posture. Okay, let me start doing this. Right, great. Chaliye. Starting with the distalmost end, the ankle joint alignment. We all know that this is the ankle joint. All right. Anybody, if you have any question, you can write it in the comment box. Okay, I'll see to it. So this is the talocrural joint or the ankle joint, and we all know that the movements that occur in the ankle joint are somewhere supposedly in the sagittal plane, although the axis is a little deviated axis, but it is classically can be considered into sagittal plane. So we can say that although it is an oblique axis around which the movement in the ankle joint takes place, but anyways, this is a particularly medial lateral axis, right? So I'll be calling medial lateral axis only to it. Fine. So in this case, the line of gravity or the plumb line falls anterior to the ankle joint. Now, if it is falling anterior, so it will allow the tibia, or tibia will tend to go anteriorly only. Okay. Now, if this is going anteriorly with respect to the fixed foot, in that case, it is favoring dorsiflexion. All right, now it is favoring dorsiflexion in normal standing posture. Now, if it favors dorsiflexion, in that case, we all should have fallen forward. अगर ये dorsiflexion को favor करती है, the placement of the plumb line which is anterior to the medial lateral axis, तो हम सबको आगे गिर जाना चाहिए, लेकिन हम आगे नहीं गिरते हैं. हम आगे क्यों नहीं गिरते हैं? Because there is a constant pull of the muscles like soleus. ठीक है ना? Although plantar flexus कह सकता था मैं, लेकिन सबसे बड़ा एक्शन इसमें soleus का होता है. कई जगह गैस्ट्रोक्नीमियस भी लिखा होता है, जैसे कि कई स्टैंडर्डाइज्ड बुक्स हैं, जैसे सिंथिया नॉर्किंस भी कहती है इस बात के बारे में कि दैट इट इज अ से गैस्ट्रोक्नीमियस एंड सोलियस एक्शन. कई बार ओटिस भी कहती है इस चीज को, गैस्ट्रोक्नीमियस एंड सोलियस, बट मैं गैस्ट्रोक्नीमियस का रोल उतना नहीं मानता, क्योंकि गैस्ट्रोक्नीमियस जो है वो अटैच होती है यहाँ पे. ओके, इट अटैचेस ऑन टू द डिस्टल मोस्ट एंड ऑफ द फीमर. सो इफ इट विल बी exerting a pull, so it will be a posterior pull to the femur. If it is a posterior pull to the femur, so the relative motion of the tibia would be anterior, right? So I do not consider the work or the motion which is being done by the gastrocnemius, right? और वही अगर सोलियस पुल करती है, तो सोलियस का अटैचमेंट जो होता है, प्रॉक्सिमल अटैचमेंट इज ऑन टिबिया ओनली, तो वो अगर पुल करेगी तो इट विल बी पुलिंग द टिबिया पोस्टीरियर ओनली. Fine. That is why there is a more significant action of the soleus muscle than the gastrocnemius muscle. Okay, so the dorsiflexion movement which is being generated by the weight or the external load, या फिर कहूँ कि एक ऐसा external torque जो कि generate हो रहा है by the weight of the body, या फिर by the falling of the placement of the plumb line की वजह से हो रहा है, वो counteract हो रहा है by the action of the plantar flexus, and that too majorly soleus. Now the dorsiflexion movement or torque, which is created by the external load, is being counteracted by the internal load of the soleus muscle or the plantar flexus, right? So this can be said. Now, the anterior position of the line of gravity in relation to the ankle joint creates an external dorsiflexion movement, as I told you that, right? That must be opposed by an internal plantar flexion movement to prevent the forward motion of the tibia, right? So this can be easily understood. Okay. The soleus muscle contracts and exerts a posterior pull on the tibia, and in this way it is able to oppose the dorsiflexion. और आप देख सकते हैं, इसीलिए मैंने भी यहाँ पे सोलियस मसल का ही जिक्र किया, ठीक है ना. मैंने I have not kept or I have not wrote about the plantar flexor muscle, right? I've written soleus muscle because I personally am not convinced with the fact that the gastrocnemius, both the heads of the gastrocnemius are also participating in the same action. Because for me, they are doing an opposite action. They are pulling the femur back. They are pulling the femoral condyles posteriorly, which eventually is causing anterior translation or a relative anterior motion of the tibia. Okay, so this can be done. I suppose that must be clear to everybody of you. Okay, coming on to the knee joint, same story with the knee joint also. It was anterior to the axis of rotation of the tibia also. It is anterior to the axis of rotation of the knee joint also. But ये शुरू होने से पहले I would like to ask you people a question. Tell me, what do we call the moving axis, moving mediolateral axis of the knee joint? What is the name we gave while you were studying the biomechanics of the knee joint? What name did we give to the moving mediolateral axis of the knee joint? Comment box. फटाफट कमेंट बॉक्स में लिखिए. हमने जो नाम दिया था मूविंग, क्योंकि एक जगह नहीं रहती है, मूव करती रहती है, ठीक है ना. जब फ्लेक्शन होता है तो नीचे आ जाती है और जब एक्सटेंशन होता है तो ऊपर चली जाती है. तो हमने उसका नाम क्या रखा था? वेरी गुड, पीपल हैव स्टार्टेड आंसरिंग. वेरी गुड, यू कैन राइट इट इन द कमेंट बॉक्स एवरीबॉडी. You can write it in the comment box. I can see the comment box here. Only one answer is what I've got till now. Good going. Write it. You've got 10 seconds. I'll change it after 10 seconds. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. Okay, very good effort. I can see the answers of Ardra, Ria, Meena, Piyush, Archita, Sonia. All of you are correct. It's known as evolute. Okay, we call it as evolute. All right, now it is the mediolateral. Evolute is the mediolateral axis of rotation for the knee joint for flexion and extension, right? Because we are considering the major motion of the knee joint in the sagittal plane only. Now, talking about the plumb line or the line of gravity, it again falls anterior to the evolute. Okay, if it is falling anterior to the evolute, it is favoring the extension moment. ठीक है ना, आगे है तो एक्सटेंशन मूवमेंट, एक्सटेंशन टॉर्क को फेवर करती है हमेशा, और इट जनरेट्स फिजियोलॉजिकली, इट जनरेट्स एक्सटेंशन टॉर्क. ओके, नाउ दिस ओवर एक्सटेंशन, सी since it is a physiological extension torque being generated here, everybody of us does not have genu recurvatum, correct? You agree with that? So if everybody of us do not have this hyperextension or genu recurvatum situation, in that case there are some structures which are still counteracting the over hyperextension torque which is being generated by the placement of plumb line. ठीक है ना, कि हमको पता है हाइपर एक्सटेंशन को फेवर करता है द प्रेजेंटेशन ऑफ द प्लम्ब लाइन और द लाइन ऑफ ग्रेविटी, लेकिन फिर भी सभी में हाइपर एक्सटेंशन नहीं होता है. वो क्यों नहीं होता है? Because of the extensive pull or the tensile strength of the knee capsule, posterior capsule of the knee, because the capsule of the knee posteriorly is quite thickened. हमने पहले भी एक बार बात की थी कि नी जॉइंट पढ़ते समय that there is a posterolateral complex. ठीक है ना, पोस्टरलेटरल कॉम्प्लेक्स में पोस्टरलेटरल नी कैप्सूल भी आती है, पीसीएल भी आता है, arcuate popliteal ligament भी आता है, oblique popliteal ligament भी आता है. So they form a thick mass and they aid to the tensile strength, and in fact eventually helps in preventing the hyperextension of the knee joint along with the active. Now these were the non-contractile tissues. Now what are the contractile tissues that help? That is the hamstring muscle. Now this time you can say that again I would say that I won't take names of this what you can say. Okay, I can take name of this thing. What gastrocnemius? I'm sorry, I can take names of gastrocnemius now, but gastrocnemius again, I won't take it take the name properly, because again we have to pull the tibia back such that the hyperextension can be prevented. Okay, because in this case it will again pull the femur back. Okay, so there's again not much action of the both the heads of the gastrocnemius, rather than the other muscles can work, right? Such as hamstrings. Okay, now the anterior location of the gravitational line in the relation to the knee joint axis creates an external extension moment. Okay, you can see that clearly here. So if this is the fulcrum and this is the perpendicular distance, so this is the external momentum. Okay, and if the hamstring is getting attached over here, okay, so if this is the perpendicular axis and this is the perpendicular from here, so this becomes your internal momentum. Okay, so this is the internal momentum and this is the external momentum. Here in the picture, if you can see that the internal momentum at some point exceeds the external momentum. Okay, but it is not like that it exceeds, it's somewhere similar to that of the external momentum, such that at the end of the day जो हमको चाहिए, external torque is equals to the internal torque. Okay, external torque is equal to the internal torque. All right, such that static equilibrium can be attained. Fine, there is an attainment of the static equilibrium. Now the counterbalancing internal movement is created by the passive tension in the posterior joint capsule and associated ligaments, usually sufficient to balance the gravitational force and prevent the hyperextension of knee. However, a small amount of activity is being identified in the hamstring also, right? Not small, there is a significant activity which is being observed by the EMG in hamstrings also, right? So you can understand it very easily and very properly. Okay, coming on to the hip joint and pelvis, this is really very important and really very interesting also. We all know that the line of gravity passes a little posterior to the hip joint, such that it creates, say if this is the medial lateral axis of rotation for flexion extension, here this is the line of gravity here, so it has a very small external momentum. Okay, although it has an external momentum posteriorly which favors extension of the hip joint. Now this extension is being counteracted by the anterior ligaments also, which are iliofemoral ligament, which are pubofemoral ligament. These are the anterior ligament and quite very thick ligaments. We all know that, we have studied during the hip joint that this iliofemoral ligament, the tension in the iliofemoral ligament helps out with the people, all those who are paraplegics. Okay, तो उनको खड़ा होने में मदद करती है, such that there is no anterior dislocation or there is no anterior falling of the patient, right? तो एक तो जो पैसिव टेंशन है इन नॉन कॉन्ट्रैक्टाइल टिश्यूज की, इट हेल्प्स अ लॉट, एंड द एक्टिव टेंशन और द कॉन्ट्रैक्टाइल टिश्यू टेंशन इज बीइंग डेवलप्ड बाय योर इलियोपsoas. Okay, इलियोपsoas is again a muscle, especially the psoas major muscle, because it is a long muscle. लंबी muscle है तो it can generate more amount of tension into it. ठीक है, so it has large greater momentum also. Fine, so this is again a muscle. So if you people remember that it comes from anteriorly like this, so this, and inserts onto the lesser trochanter. Okay, fine, somewhere here. If it inserts onto the lesser trochanter, so if this is the point of attachment and this is here, so it has a relatively greater internal momentum. Okay, this time it really has a greater momentum, internal momentum, as compared to the external momentum. Fine. So in this case also, it is being counteracted by both tension in the non-contractile structure and the tension in the contractile, or the contraction of the contractile structure. Right. Now in this optimal position, the allergy passes slightly posterior to the axis of the hip joint through the greater trochanter. Fine. The posterior location of the gravitational line in relation to the hip joint axis creates an external extension moment. Okay, extension at the hip joint, extension at the knee joint. At the hip, that tends to rotate the pelvis proximal segment posteriorly in the femoral head. Okay, you can call it as the sway back posture also. Fine. Coming on to the specific action of the trunk and pelvis. Now we have seen pelvis in relationship with the hip joint. Now we will see pelvis in relationship with the lumbar spine also. Fine. So what we have here is, in the optimal posture, the LOG passes through the body of the fifth lumbar vertebra. Do we have lumbar vertebra here? We don't have lumbar vertebra here. Okay. It passes posterior to the fifth lumbar vertebra, okay, or quite close to the fifth lumbar vertebra, I would say that's from the body of the fifth lumbar vertebra, L5, okay, and close to the axis of rotation of the lumbosacral joint. But eventually from all the other lumbar vertebrae, it passes posteriorly such that it favors extension, and it also favors the formation of the lordosis at the lumbar spine, okay. It favors that. Or you can say that people nowadays have hyperlordotic posture. It is just because all those people who have sedentary lifestyle have their big bellies, and this big belly cause the center of gravity to shift, or center of mass to shift a little anteriorly. If it is shifting anteriorly, the LOG will be going more posterior. If it is going more posterior, there will be more increase in the lumbar lordosis, right? But eventually it passes anterior to the head of sacrum, okay. It passes posterior to the all five lumbar vertebrae, but it passes through the body of the fifth lumbar vertebrae. If you can see it here, let me draw it, okay. Suppose this is L1, say this is 2, 3, 4, 5, and this is what is sacrum, okay. Okay, now this passes like this. All right, now this is posterior to the lumbar vertebrae, other lumbar vertebrae. It passes through the L5 and eventually it passes anterior to that of the sacrum or the S1. Now, since it is producing extension moment or favoring the lordosis at the lumbar spine, it is favoring the nutation, anterior motion of the sacrum. If the sacrum is lying like this, it favors the anterior rotation of the sacrum. Now, the anterior rotation of the sacrum is your nutation. Okay, so it always favors the nutation torque. Okay, now this nutation torque is again we have known to the facts of the, say, force closure and form closure. So there are other contractile and non-contractile structures which reduces the effect of gravity or the plumb line or the LOG, which increases the nutation torque. Okay, such that sacrotuberous ligament, sacrospinous ligament, the posterior ligaments which creates a pull onto the sacrum, they eventually reduces or contract with the nutation torque be generated by the plumb line. Right. Eventually, talking about the lumbar spine, all the anterior structures, which are all these structures which are lying anteriorly here, they counteract for this thing. Especially your anterior longitudinal ligament is the one which counteracts this extension torque at the lumbar spine, and your abdominal muscles, especially your rectus abdominis for this lumbar spine. Also, I can say transverse abdominis, but it can be for L5S1 and your sacral nutation. Your transverse abdominis can also work. Right, now let us see what they have to say. The gravity therefore creates a very slight extension moment at the L5S1 that tends to slide the L5 on the entire lumbar spine down and forward onto S1, right? Now this motion is opposed primarily by the anterior longitudinal ligament, as I told you, because if it is going into, if this is the normal way, if this is the normal curvature of spine, in this case all the anterior structures are going to stretch. If they'll be stretching, the primary structure which will be the restraint, primary restraint will be anterior longitudinal ligament, right, which is followed by the contractile structure, that is the rectus abdominis. Fine. So this can be done. Eventually, if you are into a hyperlordotic situation, the hyperlordotic situation will eventually cause a tightness in the erector spinae or the other extensor muscles of the lumbar spine. Fine. So this eventually results into that. Now this motion is primarily opposed primarily by ALL, anterior longitudinal ligament, and the iliolumbar ligaments also. Now, the bony resistance is provided by the locking of the lumbosacral zygapophyseal joint. I won't call it as locking, but eventually they are completely approximated, because now, as of now, if they have come into extension, they do not have any more space to move more forward or to go more posterior, right? In that case, the more approximation of the zygapophyseal or the facet joints eventually cause this limitation of motion, or cause restriction of this particular thing, okay, of more lordosis. Now, when the sacrum is in the optimal position, the LOG passes slightly anterior to the sacroiliac joint, and the external gravitational moment that is created on the sacroiliac joint tends to go into nutation. So the gravity favors the nutation torque. Okay, so that is why physiologically it is going into nutation. Okay. Now, the passive tension in the sacrospinous ligament and the sacrotuberous ligament provides the internal moment to counterbalance the gravitational torque, preventing the upward tilting of the lower end of sacrum, as I told you already. So, these are the non-contractile structures whose passive tension eventually helps us to do that. Fine. Now, the EMG studies have shown that there have been in a normal standing position without moving, in a static equilibrium sort of position, there have been studies activities recorded in the muscles like latissimus dorsi, rotators, and neck extensors. Eventually, there can always be an activity in the erector spinae muscle also. All right, there could be some amount of activity in the erector spinae muscle. Although latissimus dorsi is also a multi-articular muscle, but it is a potential extensor of the lumbar spine. That is why latissimus dorsi can record some activities. Rotators are again deep muscles. Rotator longus, rotator brevis are relatively deep muscles. If they are deep muscles, they have lesser momentum. If they have lesser momentum, in that case, they will generate lesser torque. So they are better stabilizers. So I would call not only rotators, but also multifidus would show some activity for the stabilization of the lumbar spine. All right, and obviously neck extensor. Yes, I have to keep my head erect or the neck erect. So in that case, my neck extensor will have to work with a greater amount of torque, with a greater amount of electrical activity being observed in the neck extensor muscles. Right. Now, this evidence suggests that the ligamentous structure and the passive muscle tension are unable to provide enough force to oppose all the gravitational extents acting around the joint axis of the upper vertebral column, right? Although it's not right, although yes, they are somewhere right for the upper back, for the thoracic spine, because for the thoracic spine, the line of gravity passes quite anteriorly and they generate larger external moment. If you can see here, so this is the cervical spine and this is the thoracic spine, this is lumbar, right? And from somewhere it is passing posterior to the cervical spine and anterior to this, and again posterior to the lumbar spine. So you have very less external momentum for lumbar spine, very less external momentum for the cervical spine. But you see it, if you see it here, so you have a very greater amount of external momentum being available for the thoracic spine. So in this case, the extensors of the thoracic spine at some point of time are quite unable to generate a counteracting torque. That is why thoracic spine is usually kept into hyperkyphotic posture or kyphotic postures. And this is the reason why for those people who have longer sitting hours, slouch sitting or slumped sitting is very, very, very common, very prevalent. Okay. Slouch sitting is very common because of the already present greater external momentum for the thoracic spine, right? So always remember that. Now, in lumbar region, where minimal muscle activity appears to occur, the passive tension of the anterior longitudinal ligament and the passive tension in the trunk flexors appears to sufficient to balance the gravitational extension we have already talked about. But whenever we talk about the thoracic spine, in that case, the counteracting structures could be posterior longitudinal ligament. The counteracting structures could be ligamentum flavum. The counteracting structures could be other extensors. Okay, that include your erector spinae also, or semi-spineless also. Semi-spineless thoracic especially, right? It can be your longissimus, iliocostalis, spinalis, and your semi-spineless muscle also, right? So these are the muscles which work so as to counteract the very extensive external movement at the thoracic spine. All right. Moving a little more forward. I hope I'm not going too fast, right? If you have any questions, you can write it in the chat box. I'll always be there to answer you. Okay, in the live chat, you can write the questions. I'll be taking it in the end. All right. Talking about the head. Now, whenever I talk about the head and neck, we have two segments over here, right? There could be C0, C1 segment and the rest of the cervical spine. Okay. Now, the C0, C1 segment is the atlanto-occipital segment. Atlanto-occipital joint or the segment. And this is from C3 to C7 segment. All right. In both cases, now first of all, I'll talk about the C0, C1 segment, that is the atlanto-occipital. For the atlanto-occipital, we always have a very heavy head which is placed anteriorly. So anyways, there could not be a central placement of the center of mass or center of gravity. The center of gravity will always go anterior because of the heavy weight of the face or the heavy weight of the head, you can say, that which is concentrated anteriorly. Right now, if it is going anteriorly, the log for the C0, C7 will somewhere move a little more to the anteriorly, such that it will cause, or it will prefer, or it will favor the forward falling of this what you can say of the head. Now, if it will favor the forward falling, we have to generate some amount of very strong torque which can lift it up and keep it erect. मेरा सिर ऐसे हमेशा नीचे तो नहीं गिरा रहता, तो पीछे कुछ मसल्स हैं ऐसी जो उसको खींच करके ऐसे पीछे रखती हैं और खींच करके जो मेरा सिर है वो इरेक्ट रहता है. So, talking about the atlanto-occipital joint, the muscles which act here are rectus capitis posterior major, rectus capitis posterior minor, both the oblique superior inferior, rectus capitis obliquus superior and inferior. There can be both the rectus capitis lateralis muscle. अगर दोनों साथ में काम कर रही है तो eventually it will work for this. There can be levator scapulae which can work here. Although levator scapulae C2 से शुरू होती है तो इतना ज्यादा cervical पे ज्यादा work करेगी, C0 C1 पे नहीं करेगी इतना. ये तो एक्टिव टेंशन वाली चीज होगी. पैसिव टेंशन में क्या हो सकता है? लिगामेंटम न्यूके कैन बी देयर, देयर कैन बी टेक्टोरियल मेम्ब्रेन कैन बी देयर, सो देयर कैन बी सम नॉन कॉन्ट्रैक्टाइल स्ट्रक्चर्स लाइक दिस व्हिच कैन इवेंचुअली हेल्प दैट. अच्छा, और अगर मैं आगे जाता हूं तो देयर विल बी मोर anterior and superior translation of the inferior facet of the or not the inferior facet, rather I would say that, क्योंकि यहाँ तो condylar arrangement होता है, so there will be more anterior rolling of the condyles of the occiput. So eventually the capsule of the zygapophyseal joint or the facet joint of the C0, C7, this also would be helping or being a posterior constraint or the primary constraint of the this particular deformity. Right. Now, this external flexion movement, which tends to tilt the head forward, may be counteracted by internal movements generated by the tension in the ligamentum nuchae. So, this is the non-contractile structure. Tectorial membrane, again the non-contractile structure. The posterior aspect of the zygapophyseal joint capsule, again a non-contractile structure. तीन non-contractile structures यहाँ पे, ligamentum nuchae, tectorial membrane और facet joint का capsule. Okay. Now, and by the activity of the capital extensors वो जिनका नाम मैंने आपको ले लिया है, rectus capitis posterior major, rectus capitis posterior minor, rectus capitis obliquus superior, rectus capitis obliquus inferior, rectus capitis lateralis, दोनों तरफ की bilaterally. Okay, they can work for this particular thing. Now, ideally, a plumb line extending from the ceiling should pass through the external auditory meatus, जो कि है ये. It is passing through the external auditory meatus. Okay. Of the ear, and the head should be directly over the body's center of mass, okay, or the center of gravity. Right. Coming on to the other things. Now, this is the normal alignment of the sagittal plane. So we have already talked about it, but हम लोग देख लेते हैं एक बार, पिक्चर्स के साथ देखेंगे इस बार, ठीक है ना. तो atlanto-occipital joint की अगर हम बात करें, so we have talked about it. It is anterior to the anterior transverse axis for the flexion extension, although it is again a medial lateral axis. So it is a little anterior to the anterior medial lateral axis. That is why it favors a little more flexion or falling of the atlanto-occipital joint. Now, what are the structures that favors? This one is the this one is the anterior, and this one is the posterior aspect, right? So you have rectus capitis posterior major. This is obliquus, rectus capitis obliquus, rectus capitis lateralis. Okay, so muscles like this can help, which is giving you a inferior force, right? Which is pulling it inferiorly. Okay, it pulls like this from here also, from here also. Okay, it pulls it back. Okay, so it acts on the C0C1 joint, right? Talking about the other one, the cervical. In cervical, it lies posterior to the axis of rotation, right? So in this case, it favors extension. This is the reason why we have lordosis at the cervical spine. This is the reason why we have extensive lordosis at the cervical spine. Now, what are the structures which can prevent? अच्छा, अगर lordosis जा रहा है तो मेरी गर्दन पीछे भी नहीं गिरती है बिल्कुल भी. तो there are structures, anterior structures, which are helping to pull it back. Now, non-contractile structure would include ALL. There could be annular fibers. There could be zygapophyseal joint capsule. Anterior, although it doesn't work too much, but these two things work. And the muscles could be anterior scalene, longus capitis, and longus colli. Let us see them. So if you have this is the longus capitis muscle. It stretches it anteriorly. You have an ALL over here at the center part. You have an ALL. Okay, so you have longus colli here. So these are the longus colli. And if you can see an anterior scalene, this is the anterior scalene muscle. This also pulls it like here. This pulls it, and these muscles also pulls it anteriorly. Okay, this anterior pull prevents hyperlordotic situations of the cervical spine. Although there are the plumb line or the line of gravity always passes from the posterior to that of the cervical lordosis. Talking about the thoracic spine, I've already told you that it passes anteriorly. That is why it favors deflection moment, and this is the reason why we have more stabilized kyphosis at the thoracic spine. Okay, now these structures that counteract for the same are PLL, posterior longitudinal ligament, supraspinous ligament, interspinous ligaments also. So there are three ligaments that help or that counteracts. These are the primary restraints for the hyperkyphotic posture of the thoracic spine. Now you just remember one thing and just see one very important thing. Whenever you are going into a hyperkyphotic or a slouched posture, or you have a slouched posture deformity, all these three ligaments loses its integrity. Okay, the tensile strength is being compromised at some point of time in these three ligaments. ठीक है ना, ये तीन ligaments कहीं ना कहीं आम भाषा में बोलूं तो weak हो रहे हैं. PLL भी weak हो सकता है, supraspinous ligament भी weak हो सकता है, और interspinous ligament भी weak हो सकता है. Right, now what are the ligaments which could create a active tension? That would be ligamentum flavum. Although ligamentum flavum में कोई pulling capacity नहीं होती है, but it is a very different ligament. It's called a yellow ligament. आप लोग पता कीजिएगा कि why ligamentum flavum is called as a different ligament. Now the other muscles that includes erector spinae, longissimus thoracis, iliocostalis, and spinalis thoracis, which are the parts of erector spinae, and that also includes your semispinalis thoracis. So these are the active muscle contractile structures because of what the things are being done. Okay. Now, along with this, the ligaments, there is the zygapophyseal joint capsule also, and posterior annular fibers also, which can contribute into it. Talking about the lumbar spine, we've already talked about it. It passes posteriorly, therefore it causes extension, and again it favors lordosis of the lumbar spine. Okay. Now, the primary constraint structures includes the anterior longitudinal ligament, the iliolumbar ligaments, the anterior fibers of the annulus fibers, okay, and also the zygapophyseal joint capsules. That too, the anterior ones, not the posterior ones. Okay. So the active tension is being generated by the contractile structures, that is the rectus abdominis and external and internal obliques. Rather, you can call it as all the abdominal muscles. Okay, this also includes your psoas major. Okay, because it is a stabilizer for the upper cervical spine, and it is a mobilizer for the lower, not cervical spine, lumbar spine. I'm sorry. It is the stabilizer for the upper cervical spine and lumbar spine, and mobilizer for the lower lumbar spine. Talking about the sacroiliac joint, it passes anterior to the head of the sacrum or the S1. Therefore, it favors the rotation torque. And the non-contractile structure that helps us to counteract these forces, that includes this sacrotuberous ligament, sacrospinous ligament, iliolumbar ligament, and anterior sacroiliac ligaments also. They also are there, which are located quite internally. If the sacrum is located like that, they are located like this, and they help to pull it back. Okay. Now, one muscle that helps it here, that becomes your transverse abdominis. So this one is the transverse abdominis, and this is the pull generated by the rectus abdominis muscle over here. Fine. Okay, this one was done, and we have already known about the hip joint, knee joint, and the ankle joint. Studied that one, right? Now, the common deviations that we have to talk in the sagittal plane. Sagittal plane, the most commonest deviation that everybody of us need to talk about is actually your forward head posture, right? It is the forward head posture. Forward head posture is sliding of the head forward to the body. The body stays at the same place, but the head comes out forward. We'll take it in detail while we go into the coming slides. Okay. So the mastoid process lies anterior to the body of C7. Yes, it is correct. Although there are other measures also, methods also to assess forward head posture. Forward shoulder, I would rather call it as a rounded shoulders. It is being done because of the tightness in the pectoralis major and minor muscles, right? The acromion process lies anterior to the C7. Okay, it is correct. It is the rounded postures like that. It is always being associated with your kyphotic postures, right? And also your forward head posture, hyperkyphotic posture, and associated with the protracted scapula. Okay, in that case, you have two anomalies. There is a tightness in the pectoral muscles. Along with that, there is a weakness in the scapular stabilizers, in the scapular retractor muscles. So that is why whenever a patient comes to you with a rounded shoulder, especially all those people who are coming to you with forward head posture with a history of, say, sitting jobs or working on computer from last, say, 3, 4, 5 years, they must be having a forward head posture along with that rounded shoulder. So in this case, for a forward head posture, you have to release your back extensors, you have to strengthen your deep neck flexors, you have to release your pectoral muscles, and you have to strengthen your this muscles, scapular retractor muscles. This is what is known as the we'll talk about it a little later. Now, excessive flattened thoracic or excessive or flattened thoracic kyphosis. Flattened thoracic kyphosis is not very easy to be encountered. Excessive thoracic kyphosis is quite easy to encounter. It is again a sagittal plane deformity. I told you it is associated with forward head posture and people who have excessive computer working abilities like that. Okay. So similar happens with the lumbar lordosis. All those fat people having larger bellies have more lumbar lordosis. So in case wherever there is more lumbar lordosis, the patient goes into lower cross syndrome. Okay, there can be lower cross syndrome type 1 with increased lumbar lordosis. With decreased lumbar lordosis or a flat back, it becomes lower cross syndrome type 2. All right. Now, anterior or posterior pelvic tilt could be there. It is again associated with the lower cross syndrome. If you have increased lordosis, there will be increased anterior pelvic tilt will be more. If you have flattened lumbar lordosis, there will be more posterior pelvic tilt. Right. Now, forward or backward translation of pelvis could be there, and genu recurvatum we have studied all about that. Right. Now, the pathomechanics of the postural deviation, that is the excessive anterior tilt of the pelvis. Now, let me tell you one small thing in which will take both of them along with. Okay. Suppose this is the lumbar spine. This is my pelvis. Now, there are muscles, abdominal muscles, which are working here, right? There are extensor muscles of the back where they are working here. There are flexors of the hip joint. There are extensors of the hip joint, right? So I will call it as abdominals, erector spinae. There will be flexor hip joint, extensor hip joint. Now, in case when there is increased lumbar lordosis, increased LL, right? In that case, erector spinae plus flexors of the hip joint will go into tightness. Okay, and abdominals plus extensors of the hip joint will go into weakness. Okay, So these muscles will go into tightness and these muscles will go into weakness when there is increased lumbar lordosis. It will always be associated with increased anterior pelvic tilt. Okay, it will lead to anterior pelvic tilt. All right. Now, opposite will happen in case of reduced lumbar lordosis. If there is a, I should write it here. Okay, I should write it here. Reduced lumbar lordosis. In this case, erector spinae plus flexors of the hip joint will undergo weakness, and extensors of the hip joint plus the abdominal muscles are supposedly going into tightness, but they usually don't go into tightness, right? Now, this is being incorporated with posterior pelvic tilt. There is very what you can say less prevalence of the reduced lumbar lordosis. That is the lower cross syndrome type 2. This is lower cross syndrome type 2, LCS type 2, and this is LCS type 1. Okay, LCS type 1 is very common thing. LCS type 2 is not that common. Okay, it is a little sparse. Whenever the patient will be coming to you with low back pain, you won't see it very regularly that the patient is having LCS type 2. Okay, LCS type 1 is quite common. All right, so I think we have encountered both of these things. Now let us see, they have told us about the compression, distraction, stretching, and shortening of things. Now whenever there is more anterior pelvic tilt or there is increased lumbar lordosis, okay, both of them will occur at the same time. In this case, posterior aspect of the vertebral body is पे compression होगा. There will be more compression on the posterior aspect of the body. See, suppose if the spine was like this, so now it is increased lordosis, so it has gone like this. So more compression on the posterior aspect. If there is more compression on the posterior aspect, there will be anterior migration of the disc. Okay, so in this case, if it is going more into extension because lordosis is increasing, so it is going more into extension, so the facet joint will come in more into approximation. So there will be reduced pressure in the articular surface of the facet joint. Trust me that. Okay, so interdiscal pressure at L5 to S1 also increases. Always remember this very important thing. Okay, in this case. Now the lumbosacral angle gets increased. Lumbosacral angle, everybody of you know that. Shearing forces at L5 to S1 also increases. It is said that with every 1 degree or a 2 degree increase in the sacro-horizontal angle, the shearing forces increase to a greater extent. Okay, usually the normal angle is 45 degrees for the sacro-horizontal angle, and when it is reached to the 51%, the total shearing force becomes 85% of the total body weight. It was a study done. Okay, likelihood of the forward slippage of L5 on S1, which is known as the spondylolisthesis. Okay, so such cases can lead to spondylolisthesis. Okay, I should write it here. Spondylolisthesis. Okay, now the stretching would be of your abdominal muscles. Usually the abdominal muscles gets weakened. Okay, they get weak, and there'll be shortening of iliopsoas because of anterior pelvic tilt, shortening of the lumbar extensors. Especially there is a very visible and a very easily examined accessible tightness in the extensors of the lumbar spine, that is the erector spine. Okay, talking on the lumbar lordosis, again the posterior vertebral bodies and the facet, there will be compression. Intradiscal pressure will be increased. Intervertebral foramen will be narrowed. Okay, whenever you are going into extension, there is a closure of the intervertebral foramen, and also there is a closure of the neural foramina. Okay, so in that case, if there is some structures which are compressing the nerve in the neural foramina, the symptoms of the patient would be increased. Okay, again one important thing, intervertebral foramina, if intervertebral foramina also, and there is a marked reduction in the diameter of the spinal canal also. Diameter of the spinal canal also reduces in this case. Okay, so the patient might tells you the symptoms of stenosis like that is the intermittent claudication can be important finding of in such a case, right? The distracted structures would be anterior annular fibers from the anterior side, from the anterior vertebral bodies. Okay, the stretching would be there in the anterior and longitudinal ligament. The shortening would be there in posterior longitudinal ligament. Interspinous ligament will be stretched. There will be shortening of the interspinous ligament will be there. Ligamentum flavum would undergo shortening, and the lumbar extensors again we have talked about that. Erector spinae will also go under shortening. Okay, this eventually will result in the reduced tensile strength of these structures, and obviously tightness in your lumbar extensor, that is the erector spinae, and the other muscles also, including your quadratus lumborum, including your say latissimus dorsi and other structures as well. Okay, now excessive dorsal kyphosis, when you talk about the anterior vertebral body have more compression because it is like this. More compression will be there anteriorly. Okay, it will be more compression on the anterior aspect. Okay, the intradiscal pressure is increased, more increased anteriorly. Okay, now the facet joint capsule and the posterior annular fibers are distracted. Okay, again I would tell you, if it is going into hyperkyphosis, it means the thoracic spine is going into flexion. If it is going into flexion, the inferior facet of the superior vertebra will be going anterior and superior. If it is going anterior and superior, there will be reduced articular space or reduced articular surface between the facet joint. So if the articulating surface is less, the forces which are coming from the upper body will be the same. So if we know the formula of pressure, that is pressure is equals to force per unit area. I should write it here. If you know that pressure is equals to force per unit area, the forces which are coming are same, but the area is reduced. In this case, the pressure would increase. Now, this increase of pressure between the facet joint will eventually lead to facet joint arthropathy, or what you can say, degeneration of the facet joint articular cartilage, which will eventually lead to arthritis of the facet joint, which is another name for facet joint arthropathy only. Okay. Now, there is the stretching of the back extensor muscles or the posterior ligaments and the scapular muscles also. Okay, there will be a significant stretching of all those things. Fine. Now, the anterior longitudinal ligament will undergo shortening. The upper abdominal muscles could go under shortening, although it is not quite easy for the abdominal muscles to undergo shortening or tightness, right? The anterior shoulder girdle muscles might also undergo shortness, and the other muscles such as the pectoralis pectorals could also undergo significant tightness. Talking about excessive cervical lordosis, it is the opposite of the forward head posture, right? I'll tell you about the forward head posture, but it is the opposite of forward head posture. In this case, there is a significant retraction of the upper cervical spine along with the hyperlordotic posture of the other cervical spine, okay, lower cervical spine. Now, the posterior vertebral bodies and the facet joints have compression posteriorly. The posteriorly, the intradiscal pressure also increases. The intervertebral foramen also gets narrowed. It is the same thing that we have studied in the lumbar lordosis increase. So there will be more distraction onto the anterior annular fibers, stretching of the ALL, anterior longitudinal ligament, and shortening of the posterior ligaments and the muscles of the neck extensors, especially your trapezius, especially your levator scapulae, and your capital extensors. Very important. Okay, that is the rectus capitis posterior major minor obliquus and your latissimus muscle. Okay, capital extensors, I'll write it. Okay, so this becomes quite easier thing to be studied by now. Now, if we talk about the forward head posture, so forward head posture, always remember, is associated with the hyper extension, or don't write hyper extension, just write extension of upper cervical spine, that is C0, C1 and C1, C2, and flexion of rest of the spine, rest of the cervical spine. Okay, that is from C3 to C7. Okay, there is a flexion of the other spine and the extension of the upper cervical spine, so it becomes like this. So The extensors of the upper cervical spine will undergo shortening, and the extensors of the rest of the spine will undergo weakness. Okay, the flexors of the lower cervical spine will undergo tightness, and the flexors, deep neck flexors of the head or the upper cervical spine will undergo weakness. Okay, similarly associated with that, rounding of shoulders, if it is associated, there is a significant tightness in pectoralis major minor. There will be a tightness, and there will be a weakness in the retractors of scapula. Okay, so if we draw it like this, okay, now if this is the thoracic spine, so there is a weakness of, say, tightness of the upper cervical spine muscles, there's tightness of the pectorals, there is a weakness of the deep flexor muscles, there's a weakness of the retractor muscles. So weakness will follow like this, and tightness will follow like this. So this becomes a cross. It is known as upper cross syndrome. As we have studied the lower cross syndrome, it is known as the upper cross syndrome. All right, so always remember that. So there is a tightness in the extensors of the upper cervical spine and the pectoral muscles. There is a weakness in the deep neck flexors along with the retractors of scapulae. Fine, so always remember this important thing. Now, the structural components, the anterior location of the LOG causes an increase in the flexion moment, which requires constant isometric tension to support the head. Stretch of the suprahead muscles along with the deep neck flexors, there is isometric tension and weakness in the suprahead muscles also. Okay, now the muscle ischemia, pain, fatigue, and possible protrusion of nucleus pulposus can be there in long term, although it is not that common. Retruded mandible can compress and cause irritation in the retrodiscal pad of the TMJ, temporomandibular joint. So it can cause pain in the temporomandibular joint, and chronic forward head posture patients might lead to symptoms of the TMJ. Okay, temporomandibular joint dysfunction is you can say very common in all those people having chronic forward head posture. Okay, there are consequences like that. Fine. Now, normal alignment in the frontal plane, we all know that the LOG passes through the middle of the forehead, nose and chin. So observation is eyes, ears should be level and symmetrical. We have already talked about it yesterday, so I'll just be reading it out. For the neck and shoulders, the right and left angles of the shoulders and the neck should be symmetrical. Clavicles should be symmetrical. Also, the acromion should be at level. Okay, acromion should be at level. Fine. Remember this. Now the chest, it passes through the midline of the xiphoid process. It crosses the manubrium from the center, body of the sternum from the center, and xiphoid process from the center, right? Ribs on each side should be symmetrical. Now abdomen and the hip, it passes through the umbilicus. Okay, from the xiphoid process, it crosses straight away to the umbilicus from the center. Right and left waist angle should be symmetrical. For the hip and pelvis, it passes exactly from equidistance from the ASIS, and it crosses the pubic symphysis as we have talked yesterday. Now, the anterior superior iliac spine should be at level, because this can tell you about upslip, downslip of the pelvis, right? Or if there is a significant, what you can say, tilting of the whole pelvic complex also, it can tell you about that. Now, the knees, it passes exactly between both the femoral condyles, exactly between. Patella should be symmetrical and facing straight ahead. Now the ankles, it passes between the ankles, equidistance from the medial malleoli. The malleoli should be symmetrical, and the feet should be parallel. It should not be curled, overlapping, or deviated to one side, right? From its posterior view, you can see that if you have a calcaneal varus valgus, if you can see there could be somewhat of pronation, supination. In the knees also, you can see that if there is varus or valgus deformities, right? We've talked about it again. Now, again, the transverse plane, what deviations you can see the head tilt in the transverse plane. The line through the center of the head deviates in the mid-sagittal plane. Asymmetrical shoulder height is that you can see it should be the frontal plane rather. Scoliosis is also, you can see it from the posterior. Okay, posteriorly you can initialize this. It should be frontal plane only. Okay. Now pelvic obliquity is what you can see that again posteriorly, anteriorly, both you can see that, but it requires a lot of examination before. It's not just an observation thing. Now asymmetrical hip height is what you can see, as I told you, that is known as pelvic squaring rather. Okay, you should do pelvic squaring in frontal plane. Okay, this is the method of assessment. Genu valgus varus is what you can see, as I told you, foot pronation supination, toeing in, toeing out, and calcaneal varus valgus is also what you can see. Okay, calcaneal varus and valgus is what you can see here. Okay. Now coming on to the sitting posture. Sitting posture is again a wonderful. Say I'm sitting in a very bad posture. If you can see that I'm slouched down, such that the external movement or the plumb line is coming out of my quite far away from my thoracic spine, increasing the external momentum or increasing the external moment arm, which is eventually increasing the external torque. Now, so as to stabilize myself in this posture, my extensors of the thoracic spine will have to work more to cause a static, what you can say, equilibrium, to generate a static equilibrium. All right. Now coming on to the goals of the sitting posture is same as the goals of the standing posture, is to attain a normal alignment with low cost of energy. Always remember, least expenditure of energy should be there, which will eventually lead to least work done. Okay, again, and least power and everything least. Okay, and low force, obviously. The greater distance that the LOG is from the joint axis, larger moment that is created for the external load, that is the body weight. Okay, such that it will have to, our internal forces have to increase so as to counteract it. Now, more muscle activity and or passive tension in the ligaments and the capsule is required to maintain the equilibrium at this point of time. Okay. Now, the necessary increase in the muscle activity resulted in more energy expenditure, and this is what we do here. This is something what the physiotherapists do. This is the reason why I told you, you should always remember, you should always take a very comprehensive assessment or examination of the people who are coming to you, because if they are into too much of the sitting posture, they'll eventually slouch down. If they are eventually slouching down, there are more muscles which are working to counteract this position. If there are more muscles which are contracting, they are utilizing more energy. If they are utilizing more energy, the muscle will get fatigued earlier. So it is a high cost energy work. So you just have to strengthen those muscles. You have to just correct the posture so that you are minimizing the expenditure of the energy. You are ultimately making it a low cost energy effort. Similarly, in this position, see, this is an active erect sitting. So in this, there are a lot of extensor muscles which are firing. Okay, in this case, from the thoracic spine, from the medial lateral axis of the thoracic spine, although the external momentum is quite low, but there is extensive work of the extensor muscles which is already being done. Now, in this situation, it is a relaxed sitting position, relaxed erect sitting position. So although the external momentum is a little larger, suppose this is external momentum 2. So this is external momentum is a little larger than external momentum 1, but there is reduced, quite reduction in the activities of the extensor muscles. The extensor muscle activity is not that much as it was in case of the active erect sitting. All right. Similarly, when we talk about the slump sitting, it is a very bad postural sitting because there is very, very, very large external momentum. So this eventually leads to more passive tension to be generated in the non-contractile structures and more torque to be generated in the contractile structure. So eventually this position is quite bad for everybody. Although this position can be attained because it is somewhere, the external momentum somewhere between the first and the second, and at the same time the muscles are not working here. So if the muscles are working here, it is again a high cost energy work. Here contractile, non-contractile both are working, so again it is a high cost energy work. Okay, so this is a scenario where the muscles are also relaxed, there are non-contractile structures are also relaxed, so it is eventually a low cost energy workout. Okay, because it is being seen that in this position also muscles like latissimus dorsi, erector spinae, they are working. There are electrical activities being recorded in this position. So if they are working, it is a high cost energy. Now, if although there will be work in this position also, but there will be quite less amount of work which is being done by those muscles here. Fine. So this is what has been asked or talked about in this particular slide, that they are saying that LHG passes quite close to the joint axis of the head and spine in the active erect position. In the slump posture, the LHG is more anterior to the joint axis of cervical thoracic lumbar spine than it is neither active or relaxed erect sitting. Therefore, we would expect that more muscle activity would be there in the slumped posture than the other sitting postures. There will be most high energy work in the slump posture, right? So never try to promote the slump posture. Always try to correct it. Now, activity of the superficial lumbar multifidus, thoracic, erector, spinae, and internal oblique abdominal muscles were recorded in erect and slump sitting posture. So all these muscles are working, making it a high energy posture, high energy consumption posture. Both of them, erect, active erect also, and slumped also. Okay, consumption. Okay, so in this case, what you should do is you should go on to a posture which is a low cost energy expenditure. Okay, so that is your relaxed energy, relaxed erect sitting posture. Now, this is a very important slide which is telling you that how the intradiscal pressure changes with different postures, right? Whenever you are lying, see that the most smallest curvature, the most smallest graph that comes here is the whenever you're lying. So the pressures onto the disc are least whenever you're lying supine. Whenever you are lying in side lying, eventually it increases, although it is less than say 100% of the original body weight, but eventually it is more than 50% of the body weight. Somewhere it is around 75% of the total body weight, right? So always remember that the least amount of pressure which is being exerted, or the intradiscal pressure, it is there in the supine lying. The supine lying position is quite safe for the people with herniated disc. This is the reason why there are most of the clinicians that favors what you can say bed rest during a PIVD cases. But eventually, bed rest imposes a lot more other anomalies as compared to the other activity sort of things, right? Whenever the patient is in a standing position, there is 100% of the body weight which is falling onto it. Whenever you are bending forward, semi bending without carrying any weight, okay, bending slightly without carrying any weight, the pressure on the disc eventually increases more than 200%, right? It increases more than 200%. Okay, these are the findings of the two studies which were performed by Wilk and Natchinson, right? So Wilk tells you that it is around more than 200%, and Natchinson tells you about it's more than 150%. So eventually it is somewhere between this. Talking about sitting, normal sitting, or you can say that it is an erect sitting position, right? In erect sitting position also, it is quite more than 100. So Wilk tells you that it is quite a little less than 100, but Natchinson tells you that it is more than 100, right? So eventually it has a greater amount of intradiscal pressure when you are into erect sitting also. When you are into slouch sitting, as this is the position while you attain whenever you are sitting onto a computer, right? Or longer hours of sitting onto the computer. So the intradiscal pressure enormously increases, right? It increases more than 150% of that of the body weight. Whenever you are into a relaxed sitting or a slouched back sitting, okay, you are pushed back sitting, okay, your trunk is pushed back, so the whole weight of the trunk is being transferred over the backrest of the chair. So in that case, the intradiscal pressure sufficiently reduces. It reduces even more than that of in the sideline. Okay, so it reduces more than 75% of the body weight, although it is quite a little more than that of the supine lying, but it is less than the other postures also. Now, if you are carrying a weight and you are bending forward, this is the highest intradiscal pressure percent point, right? So this is the reason why bending forward is strictly prohibited in the patients with disc prolapse cases or herniated disc cases, right? So it eventually creates largest amount of pressure, more than 450% of the total body weight, right? So this is the most avoidable sort of situation whenever we are treating patients with, or whenever we are suggesting patients with, say, herniated disc. So whenever you are lifting a weight with erect spine and the weight is being lifted between the legs, so that is, it lies within the base of support. Although it eventually reduces the intradiscal pressure, but at the same point, it is quite more than that of the other postures, right? Without carrying weight postures. Fine. So it is nearly less than, quite little less than that of the 350% of the total body weight. And whenever we talk about that of the lifting weight in close to the body and at the same time into erect standing posture, although it is less than that of the bending forward and between the legs posture, but it is more than that of the other postures. Eventually it is quite similar to that of bending forward without having a weight. Okay, so bending forward without having weight and erect standing while carrying a weight imposes same amount of intradiscal pressure. All right, so this was a very important slide, or an important what you can say, graph that I wanted to share with you people. Now coming on to probably the last slide of the day for us. So it is a flexion relaxation phenomenon. So don't apply too much of mind onto it. Just listen to a small story that I'll be telling it to you. See, this flexion relaxation phenomenon is totally based on forward bending, right? So whenever I'm trying to go into forward bending, it is not the flexor of my lumbar spine which is causing this forward bending. Although it is the flexion of lumbar spine which is being carried out whenever I am forward bending, but it is the extensors of the lumbar spine which are eccentrically working and allowing me to go into forward flexion of the lumbar spine. So they are working eccentrically, and slowly they are allowing me. Now, as and when I reach complete flexion, the external momentum eventually reduces, and so as the internal momentum, because it comes closer to the axis of rotation. So if it is coming closer to the axis of rotation and the internal momentum reduces, so as the activity of the erector spinae also reduces, which was working eccentrically. Okay, so whenever it is reducing, it is called the relaxation phase in the flexion period. Okay, relaxation of the extensor in the flexion phase. So this is the flexion relaxation phenomenon. Along with that, when I reach complete flexion and when I just leave my weight like that, so it is the point where the whole spinal load is being what you can say, bared by the non-contractile structure, that is the ligaments and the other annular fibers of the intervertebral joints. So all these non-contractile structures at this point are bearing the whole load of my spine, and there is no electrical activity being recorded at this time in the extensors of the lumbar spine or the erector spinae. So this phase is known as the phase of electrical silence. Okay, so always remember that whenever I am bending forward, suppose I am bending forward like this. Okay, so at this point of time we have a certain amount of momentum here and this way, so it will allow me. So at this point of time, erector spinae will work eccentrically, but as and when I go like this, okay, and this, so if this is the axis of rotation and this is the center of gravity, center of mass for the upper body, so the external momentum eventually reduces at a greater extent. So if the momentum reduces at a greater extent, in that case it will always be that the contraction capacity, the force of contraction of the erector spine will reduce as I have reached the complete as I'm trying to reach the complete flexion of the lumbar spine. So eventually this will be known as the flexion relaxation phenomenon. And when I reach complete flexion, there will be the phase of electrical silence where no muscle activity is being recorded in your erector spinae muscle. All right. So this is something what I always wanted to tell you here. So if you have any questions by now, you can please come forward and ask me. If you have, let me check if you have written anything over here. And this. Okay, no questions till now. So if you people have any questions, you can write it here. I'll be waiting for a while. and then we'll be ending it. If you don't have any question, any questions, any questions? If you have any questions, you can please write it in the comment box. I'll be there to see this. If you don't have any comments, that's okay. We'll stop with today's live streaming. Okay, after that also, if you have any questions during the days to come, you can contact me or on any sort of social media. You can just ask me the question. I'll always be there to answer. Okay, you can write to me on my email. You can write to me on WhatsApp. You can write to me on Telegram. You can write to me on Facebook message. You can write to me on my page. You can write to me anywhere I am accessible. Okay, so you can write to me anywhere. And please don't forget to subscribe the channel and share it amongst other people also. Right? All right. So thank you so much, everybody, for being here. Okay. So somebody's there. The question is, kindly repeat the thoracic kyphotic curve in spine. Okay. While I'm talking about the thoracic kyphotic curve, so if I am like this, there is a physiological curve, the curve which is being present since birth. So if it is being provided like this, the normal existence of the plumb line is quite anterior to the spinal, to the vertebrae of the thoracic spine. So physiologically, there is an increased external momentum for the thoracic spine. Now, if we are working more on computers, or if we are sitting in slouch posture for a long time, this eventually goes a little more forward. If this is going more forward, the external momentum because of the body weight is eventually increasing for the thoracic spine. Now, if this is increasing, the posterior structures which are lying on the thoracic spine, they'll go under stretching, especially the supraspinous ligament, especially the posterior longitudinal ligament, especially the posterior capsule of the facial joint of the thoracic spine, and the contractile structures like erector spinalis, semispinalis thoracic muscle, they'll all go under stretch, and the contractile ligament structures will try to contract and pull it back, being the primary restraint structures. So if we stay to be in the same position, those the non-contractile structures would be losing its tensile strength, and the contractile structures would be losing its contractile strength. Okay, so this was something about the kyphotic curve in the spine, thoracic spine. Okay, any more questions do we have here, or shall we end it for today? Do we have any more questions here? All right, thank you so much for being here, and I'm so happy to tell you people that by this we have successfully completed 2 modules of the online biomechanics classes out of 4 modules. So we have completed 50% course of the biomechanics here. So for the next week, we'll be starting with the biomechanics of the spine. And trust me, everybody, this is going to be an amazing joyride for everybody while studying the biomechanics of spine. Thank you so much. Stay tuned, stay updated, stay connected with us. Please subscribe, like, share our channel and our videos. Stay home, stay safe. Thank you so